I'm taking the view that newly diagnosed patients with relapsing-remitting multiple sclerosis should be treated aggressively at the start, and that is based on the evidence that early relapses and uncontrolled, sometimes missed relapses could actually worsen the disease progression and early appearance of disability. So what I have done in my presentation is I have given an overview and then presented an illustrative case of a patient who was diagnosed with relapsing-remitting multiple sclerosis and was treated with the very traditional escalation form of therapy, starting with the standard platform therapy of injectables before gradually moving up the tier. And by the time we were able to offer her high efficacy choices, she was quite disabled with a relatively small prospect of returning back to previous functional level. What I have demonstrated in my talk is the fact that by avoiding high efficacy choices, you are merely delaying the option rather than avoiding it. So when you start off with perhaps more simpler choices, which is usually guided by safety concerns more than efficacy issue, you feel that the treatment will work for the patient. Now, for those, the treatment is not effective. It will take over 2 to 3 years to be switched to high efficacy choices, which will do quite significant harm in terms of the progression of multiple sclerosis. So my point is that patients who have an active disease at the presentation of relapsing-remitting multiple sclerosis should receive aggressive high-efficacy therapy because they will require the treatment at some point, and by avoiding the choice, you're only delaying the effective option of controlling the disease.